hours from Kampala into 4 rural districts, here's what I'm finding on the streets of the village. $3, $9, $10 treatments, absolutely sky high beyond the reach of people. And the only thing in the affordable range is in the Fansidar chloroquine category. So I'm getting the sense that even with Novartis's pledge of 36 cents for a pediatric treatment, by the time it gets to the rural streets in a Ugandan village, it is way outside of anyone's reach. So once we've studied this, then we begin to hypothesize an answer, and then be in partnership with others, most of those who've worked on the AMFM. And we begin to hypothesize an answer that says, you know what, in these rural villages here, then if we could just bring that price of the drug, now that it's up at the $3 range at the retail center, down to a price that's going to be competitive with these 12-cent chloroquine treatments, then how do we make that happen? How do we bring a quality ACT, which happens to be Coartem, into this rural setting and make it affordable? And so the pilot that we've done in Uganda is in essence a carbon copy of what we will see as of 2 days ago propagated around the world through the AMFM. We've documented work in Uganda. The Lancet has accepted our comment. This is now not just a cute project that MMV did. This is validated in the scientific journal. And so when we look at the AMFM policy debate, and it is a debate because there are skeptics that the AMFM is going to be a boondoggle, it's going to be a waste of money, then what we're saying is let's use evidence to fortify the pre-AMFM. Let's build evidence with the AMFM. And at the end of the day, we think that this contribution to the affordability mechanisms has been a very important piece of work. So for those of you who did not catch this news, 2 days ago, the Global Fund did approve 9 countries for a subsidized mechanism. In essence, it will look similar to what we've done in Uganda and the Clinton Foundation helped do in Tanzania. And so going forward, MMV will continue to accompany the rollout of this process in a couple of key countries and working with partners like the Clinton Foundation and the AMFM Secretariat here in Geneva to make sure this gets a real fair shake. So in availability, then the question here is, if you're starting in Kampala, as an example, an African capital city, then if you're trying to figure out why people are dying in Paisa from lack of medications, you need to start saying 2 things to yourself. Who should be getting the drugs there? What's incentivizing them to get there? And how much is it costing? Think big picture, though. This is not just about private sector distribution. We also want to know in the public sector who is accountable and who is making the drugs available there or not. So one of the things that we are doing is collaborating with research organizations like the University of Oxford that's proven in Kenya that you can systematically, regularly go beyond the headquarters, beyond the central medical stores, and measure what is the availability in the public sector system at the rural health post, the district hospital, the provincial hospital, and the depots. We'd like to see this done in 5 or 6 more countries to prove that the public sector supply chain problems are not a great big black hole that can't be solved. You just have to be rigorous and study the problem carefully. With partners like Kemry, University of Oxford, we think we'll get there. And the other thing that Kemry, University of Oxford is helping us think about is, well, what if the drugs are getting there and they're not used right? What if the drugs are getting there and they're not being diagnosed before they're treating patients? This kind of R&D in the access setting for our work is just as important as the R&D in the clinical setting, because at the end of the day, we want the drugs to be used right. And lastly, on availability, I would point out an innovation that we as an organization are very keen to do more work in, which is the use of community health workers going down into the villages where the health system literally may not be present in any semblance, and get involved in the distribution and diagnosis of malaria and distribution of treatments. And so it's an exciting area because it's evolved from simple chloroquine pilots in the early 2000s to using RDTs today. So you're actually diagnosing patients in the village, not treating the fever presumptively, and you're actually beginning to do integrated community care management of kids who are sick. Malaria, diarrhea, or a respiratory infection. The only thing I'm going to point out here, this is all the mapping that we have done about the home-based management programs. In Mali, Malawi, we will have an exciting partnership with PSI to take Coartem dispersible down to that village level. A couple of slides on acceptability as I wrap up. And so acceptability has 1,000 nuances. Acceptability starts, I think, at the very end. Are the patients going to accept the drug and use it right? And to do that, then you have to be willing to work with your pharma partner to make the drug as simple and clear, and what you're trying to do is ensure compliance. So this example with Coartem dispersible is one that we are rightfully proud of Novartis for having seen the importance of making sure that you're doing everything possible so that a mother who may not be able to read is going to finish administering the drugs correctly. Novartis has also invested heavily in making sure that the training materials for perhaps the 6th grade education health worker are also going to be acceptable. And beyond patient and health caregiver, we have to ask ourselves as MMV, are we listening to the voice of the market in terms of policymakers, both internationally and locally? Are we listening to what malariologists are telling us in the countries? Are we even listening to what national logisticians are telling us? Believe it or not, we've had one country tell us, if you don't reduce the packaging on this one product, we're going to go with a generic. And we're saying to ourselves, it's a package. It actually helps patients comply. If that country says to us, sorry, it needs to fit in this smaller box to go out to the rural village, we have to be able to engage that kind of a dialogue. It's not tidy, it's not logical, it's a barrier. So my last slide here is a bit of fun poking at myself and the board and the people I work with. This is, anyone know what this is? This is plate number 10 from the famous, yes, thank you. I didn't know what I've never seen a Rorschach drawing until I went on the internet last night. This is plate 10 in the Rorschach drawing. Basically, when we talk about access, what I have found is there's one interpretation of access for just about every piece of DNA that walks through the front door of my office. Okay? R&D over years has developed something which is fairly consensus-driven, fairly agreed-upon standards. Access is a brave new world. It is open to many interpretations, and I think that this process of engaging MMV in a dialogue has been very enriching for me, for my whole team, but it's not always been easy. So at the end of the day, I hope that a cleanly described vision, you'll go home thinking you have a better sense of what we're trying to do. The vision's very simple. We do want a world where free or easily affordable medicines that we've helped develop are always there to treat whenever someone who has malaria needs that life-saving treatment. And the mission then is to ensure that these countries that we're working in will get a sufficient amount of it so that we can make a health impact now. And if that's too much words for you, then I hope this picture tells it for you. That's the mission. Child is sick, child gets treatment.